doing research on laundry and textiles for a very long while now, maybe 12 years. And I did start my career many, many years ago as a fabric technologist and then trained to be a microbiologist. Why? I don't know, but that's the path I took. So as well as having sort of the microbiology infection control background, I do have a background in textiles, and the two merged together, and that's how I ended up doing research on cleaning of textiles, because there's an awful lot of focus on hard surfaces, non-porous surfaces, and sometimes those porous textiles are maybe a little bit forgotten, and it's about what risk do they really pose, and where is the evidence and the education around that role that textiles plays in infection control. So this is what we're going to talk about. So I've done very briefly, which now I'm quite pleased I can talk about a little bit more in depth, 3 overviews of 3 projects that we're currently working on or have previously worked on, and I'm going to sort of give you an overview of each of those and how they relate to textiles. So we're going to talk today, or I'm going to talk today, about C. difficile, which is the gremlin. That's the one I call the gremlin of healthcare laundry. And we're going to look at some research that was actually done a little while ago, but has become very relevant again. We're going to talk about the bioindicator test methodology that's been developed and is going into 14065, so the risk management guidance or standard that is for healthcare laundries. And we've also been working post the pandemic on guidance and education for care homes around laundry and the decontamination of laundry. So we're going to briefly talk about those 3 projects. So the rise of C. diff again, because this research was actually conducted in 2007 to 2010, when there was the first sort of large uprise, if you like, of C. difficile, and we were seeing lots of isolation wards, etc. So there was a need at that time. That actually waned off a little bit, but we're starting to see that rise of C. difficile again within hospitals. So since 2021, there's been consistent rise of C. difficile cases. And we've got a newly evolving ribotype, which is the 955. And what we're seeing from this ribotype is that we have had 2 large outbreaks in hospitals and has caused mortalities, and it's not responding to first-line treatments. So it is an issue from a healthcare perspective, but from an environmental survival cleaning perspective, it's also an issue. Because why are we so concerned about them? Why are they so hardy? Spores, unlike the vegetative cells of C. difficile, have an exosporium, which is like a protein coat on the outside, which is extremely hardy. And it allows that spore to survive in the environment for very extended periods of times. There has been, where we're looking, over a year at least. So those spores just sitting there. They're not causing disease at that point, but they're very, very resistant to most disinfectants as well. So they're resistant to disinfectants. They're able to survive in that environment. And with C. difficile, and I know there's someone talking later more in depth about C. difficile, is the fact that you don't necessarily need a high infective load. So just a few spores can cause infection. So in terms of being a gremlin in the healthcare environment, this is definitely one of them, because how do we get rid of them? So where my focus was particularly was on bed sheets, because when we're talking about C. difficile patients, we're talking about patients that obviously have got severe diarrhea, which is going onto the bed sheets in the first instance. And so that removal of that infective waste from those sheets is critical. And there was lots of questions around how well spores are attaching to textiles, how do we remove them? Now, these bed sheets are specifically going to industrial launderers because they're classed as infectious waste. So the first thing we did was just had a look if we're using a 71-degree wash with and without detergents. I've got a laser here, haven't I? Is it working? Can anyone actually see that laser? No, I'll point. Okay, so we were looking at how it would just survive if we did this in the lab. And what we've got here is the initial inoculum of spores. So this is the black, is how much we put onto that textile. The grey is a piece of sterile textile in the wash. So is there transference within the wash? And then the white block here is what we were able to recover. So this is very high load, but we need to put a high load on to be able to establish what that reduction is. So we did it without detergent with what we call a type strain, which is just a strain of bacteria that you can just go and buy. Well, you need a license. You can't just go out and buy some C. difficile. So you know, we have to handle it properly. It's not on the Tesco shocking list. But we had to go and buy those type strains. We had to look to those. But we also looked at a ribotype that had been recovered from a patient because they can behave differently. And what we did was we did the 71-degree wash in the labs with and without detergent. Now, you may look at the ones without detergent and think, well, yeah, obviously there is quite a bit of survival there. However, the ones with detergent, they look okay to me. You know, there's only a small number. But one thing you've got to remember is us microbiologists, we don't like to make things easily, and because there's so much bacteria, we work in log scales, so it's tenfold up all the time. And what we were seeing was there was survival. And we think the infectious dose, it hasn't actually been proven yet what the infectious dose is. It can be as low as 6 spores. So the fact that we were getting some spores surviving and we were getting transferred to textiles in that 70-degree wash was a little bit of a warning sign. But this was in the lab, which is very different to what's happening in real life. So this is us with our pipette putting our spores on this piece of textile and putting it in the wash. So this initially for us was like, detergent plays a key role. We've currently got another PhD student working on bacillus spores looking at industrial washing with detergents. And absolutely, the detergent is the key thing against spores rather than temperature, because temperature, we all know, doesn't affect those spores. And what we also did was we looked at what was happening within the textile with these spores. Now this looks like we were very clever and we did a partial wash and then a full wash, but actually the machine broke down. So I said, get the sheets out and we'll have a look at them then, but it works quite well. So what you can see here is the actual spores embedded within the fibres of the textile, which I think is quite important. So on this side, we've got where we stopped it mid-wash, and this was after a full wash. And you can see those spores are quite clearly there and within that weave of that textile, which is obviously not where we want them after we've washed them. And we really want them removed. So that's after high temperature washing. So it's had no effect at all on them, basically. And it's quite nice to see where they are within that textile. So the question then was really, why are they attaching to these textiles so well? And you might be able to see here, you do have to look hard, but what we're seeing is little appendages coming out of the spore and attaching to the textile. So this has been seen on some agars and other surfaces before, but what we actually think is that they're like almost attaching to the textile, which then makes them quite difficult to remove. We did some more research, which we haven't got here, but I'll talk about because I've got a little bit of extra time. We actually looked at how long the spore was on the textile to how difficult they were to remove, because as you know, your clinical laundry goes into a bag, it goes into the sluice room. Very often then it goes and sits outside the hospital till whichever the laundry provider is comes and gets it. So sometimes that can be a number of days, but by the time it's gone through that process. C. difficile spores are much harder to remove from the textile the longer they've been on them. So it is key that if you've got an infected patient with C. difficile, that you try and get that through the laundry process as quickly as possible. And what we also did was some experiments to start breaking down those spores and see if we could reduce the attachment, which you can. So it's the outer coat of that spore that's really making it attach very well. So then what we did, and this was an absolute nightmare, was we were going to go from patient, from ward to washer. which meant we had to keep the sheets that were on that patient's bed through that whole process of getting bagged up, the laundry collecting them, through their wash process to retrieve them. So we used blue sheets because we thought this would be easy, but the amount of sheets that actually got lost, a month's of work that went into this to just get a small amount of data, we just couldn't keep up the sheets. But we did manage it. So we managed it. And what we were doing was basically taking the sheets from the patient's bed, taking them, they were getting bagged up, so it went through the same process. We were then taken to the lab, cutting a section of the soiled area out so we could see how many spores were there. We were then taking those sheets to the industrial launderers. They were laundering them at high temperature and also through the calendars, which is the high pressure, high temperature dryers. Then we were taking the sheets back to the lab because we'd marked where the soil area was. We were taking another sample and seeing how many spores were left. So here we haven't got the laser, but pre-wash, we were seeing about 51 colony forming units. So we would say spores per 25 centimetres squared of textile that was coming directly from the patient. Post-wash, there was still 33 there. So what we were actually seeing was that this was a lot less effective than what we were seeing on the lab when it was a really controlled environment. And this was used, we then typed it to see which ribotype we had, what was coming off the patient. So it's still there. And I always said in those outbreaks from post-2007 onwards, we were seeing quite a lot of sporadic outbreaks all over the country. And one thing I say about laundry is the sheets go into laundry, but you don't necessarily get the same sheets back. So we can't prove it, but it could have contributed potentially. Now, the industry is investing money into the research of spores on textiles, so the industry is aware of this and moving towards it and looking at new technologies in which we can reduce that spore contamination on the bed sheets. So it is an area that is being worked on, which is good. So, see where we are. So that's a bit of an overview of spores and where the gremlins are and things that you need to think about. And one of the key things would be get it through the laundry as soon as you can, so you're not allowing that attachment to happen if you end up with an outbreak of C. difficile. And work with your laundry provider so that they know that that's what's coming in and they can deal with that. So many years ago, pre-COVID, COVID did interrupt this research. We were commissioned to create a new test standard for the industrial laundry industry because at the time what was happening was there was lots of different methodologies that gave lots of different results to show how efficacious their disinfection process was. And the industry were like, we need to standardise, we need to be all on a level playing field, we're able to prove to our customers and for the health of the patients that are using, whether it's the bed sheets, whether it's the healthcare worker in the scrubs, whatever it may be, that the textiles that are coming out are fully disinfected. So we did quite a lengthy piece of research, and we have now published this research, the paper's there. So that is open access. It's quite science heavy, but it is the development and the process of developing this test standard for the industry so that when your textiles are coming back into your healthcare settings, that you know that the disinfection has been fully validated in a way that proves kill. And that's what's really important. A lot of the methodology that looks at the decontamination of textiles is often looking at dilution because you've obviously got all that water in the wash and so we're washing them away, but that's not killing them. Where are they going? Are they going back onto other textiles? Are they going into the drain? Are they in the machine? Where are they? But the test methodology that we've developed shows it kills. The dilution is then an extra bonus on top of that, rather than it being the reliance on that dilution factor. So we can see that. So first thing was a survey. Now this has been funded by the US, Europe and the UK. So the money's come from globally to support this. And the first question I had is, well, what's everyone doing now? How are they testing now? How are they showing they're disinfecting? And what basically come back was some people were looking at the kill of the microorganisms in the wash, and some were looking at bioburden of processed linen, so how clean was it when it come down. And there was a whole array of different methods that were going on, so swatch testing, so where people were just leaving some bacteria on the swatch, but then, as I said, the dilution was washing it off. There was a couple of laundries using a commercially available bioindicator strip that was available, and then the destructive and non-destructive was basically cutting bits of the textile up and seeing what was there. And so there was lots of different ones, but basically it was a little bit like choose the method you want to get the answer you want, because some test methods are much more rigorous than others, and this was going on universally. So the key thing here, as I mentioned about the dilution, is that you can use fabric swatches, contact plates. Sometimes people will put contact plates on. It's not a very good method at all. Some people doing swabs, dip slides, but none of that is accounting for kill, really. You're just looking at what's been removed, whereas retention with the biological indicators, which I'll show you how they're made up in a moment, is really measuring kill. And the issue with this, choose the method you want to get the answer you want, is how do you know that the laundry provider you're using is killing? And I think this really comes to be an important point when we talk about spores. So the bioindicator looks a little bit like this, and then within each section, so these are the commercially available bioindicators. In each of these sections, you've got 3 logs of bacteria in here, 4 logs, 5 logs, and then 6 logs. So you can start seeing what your level of kill is. Now really, we should be achieving a 5 log minimum reduction when we're looking at the standards. And basically within each of those little compartments, you've got a bit of textile that's been inoculated with Enterococcus. Now the reason Enterococcus is chosen is that it's very thermotolerant. So it's your worst case scenario, because we're obviously talking about high temperature laundering here. And the strain that they were using, the commercially available ones, currently commercially available ones, is pathogenic. So this means putting pathogenic bacteria into a wash to ascertain whether it's killing or not, which I had a little bit of issue with. So we'll move on to that point in a moment. It's semi-quantitative. It isn't saying you've killed exactly this. It's just giving you an indication of the kill. So is it 5 log, 4 log? So you're just trying to get to that 5 log. If we're talking about more pharmaceutical type laundries, then you'll want to take that up to 6 logs. But this test allows you to do that. So what we did was, once we knew that this test worked, we looked at the 16616 method, which is quite complicated because you have to put so many swatches in, you have to stop the wash part way through, you have to add a lot of blood, you then have to stop the wash. But that's one of the test standards that's out there, so we did compare it to that. We took the commercially available bioindicator, which I might add only works at 60 degrees and above. The membrane itself doesn't allow for low temperature washing to be validated, which when we're moving to a more sustainable, environmentally friendly wash process, which they're trying to move towards low temperature, less use of water, isn't ideal, because that's where the sector wants to move in the future. And how are we going to validate them? Because this membrane only works at 60 degrees above. So we did a lot of work around the membrane. So we've now got a membrane that works at low temperature washing, so we can validate at low temperature. And the other thing is, we did a lot of work. We wanted to put a strain of bacteria in there that, if it escaped during the wash, wasn't going to contaminate everything. So we turned to the food industry and we looked at cheese strains. So we found a non-pathogenic cheese strain that behaved in exactly the same way as those ones that infect people, so that we were able to use that as a model. So it is still a class 2 microorganism in the UK, but it's non-pathogenic. So we've done an awful lot of work with the HSE and the HSA on the safety of this and whether it is a viable option. So what we did was we looked at all these different methods and we put them all in the wash to see how they performed. And the the 16616 requires lots of contaminated swatches and sterile swatches, but it also requires blood within the wash. So it would mimic more what you would see if you had the laundry. So we did put blood into the wash, and some of the German funders wanted us to put blood in the bioindicator as well. So we did do that. So the PES membrane on here is the new membrane that can be washed at low temperature. The DES membrane is the commercial one. You can imagine how confusing this got when we were analysing the results with PES and DESs. In the end, I said, can we call them old and new? Because I couldn't get my head around this at all. So the ones where the blood was in the bioindicator, we didn't see any reduction, which we'd expect. The cells are too big, they're blocking the membrane up. But we did it because we were asked to do it. However, where there was just blood in the wash, what you can see here is when there's blood in the bioindicator, it's not working, which is fine, we knew that. This is the new membrane, and what we're seeing when there's blood in the wash, that we were able, so it's the orange bar that we were interested in, we were able to get the kill with the new membrane. And with the DES controller, you can see, because this is ambient temperature, so we've done it at low temperature to prove it works, that it obviously wasn't working, because we already knew that it needed to be 60 degrees above. And then we were looking, the other orange bar is the 16616. This is the open swatch test. And what these are is cross-contamination. The blue bars are the cross-contamination to the sterile swatches. So what you're seeing is we're getting little to no cross-contamination with the PES, with the new bioindicators. But when you're looking at 16616, because it's an open swatch in the wash, you're getting contamination on other samples, which you then have to take into account when you're calculating your disinfection. So what we're saying is this is much straightforwarder and much simpler within the wash. So positive points then of the different test methods are that basically in 16661 detergents easily gets access to the swatches and you can measure the exact level of bacteria. However, we're saying it's really measuring a dilution effect, you're seeing cross-contamination, you need to be able to stop the process in the middle of the experiment, which means it cannot be run in real-life laundries, whereas the method that we're proposing is going into 14065 as we speak, although it is a very lengthy process, can be actually run within the laundry, so we know it's working in that scenario rather than just a mimic scenario. Can contaminate the machine, etc. DES controllers only work at 60 and above, which is a real issue as we move forward to more sustainable technologies. And the PES indicator, there's very limited, the negative on that is there's very limited resistance to some detergents crossing the membrane. But what we're saying is we think this is a really good real-life test method that can be used within a laundry to prove disinfection. So we've put the recommended strain forward to the UK HSA and worked with the HSE representative for the laundry industry, and they're happy because we've proved it's non-pathogenic, it's only being used in controlled risk-assessed laundries that are already handling these types of microorganisms. So we've had all that approval. We know it's a semi-quantitative procedure. The industry is now working on the frequency of how often this test should be done. So it's definitely for any new technologies, any new processes that are put in place, and then they're working on how often beyond that it should be used to validate laundry testing. They're also doing analysis on cost. We are going through the process now of writing up the accreditation for those labs that will be able to provide this service to the laundries, so that we're ensuring the labs that are processing those bioindicators post them going through real on-site laundries, that they're able to do the test and of the standard that they need to be. So we move away from this let's use any test to show the results we want type approach. We're also writing guidance for the labs and the laundries, because one thing is the laundries particularly need to be aware of how to handle those bioindicators and what they need to do with them when they come on site, and what do they do if it splits is the other thing. We've only had one ever split, so I'm quite confident they won't. And And it's currently being put as an appendix in the 14065, which is the risk management ISO standard that healthcare laundries require to process healthcare laundry, basically. So it will become part of an appendix as a test methodology in that standard. And this will hopefully give you all confidence that those textiles that are coming back and the processes that are being used to disinfect those textiles are of the standard that's required. And we're working with the textiles industry now to look at how we process spores in the bioindicators. Slightly more tricky, but we're in the process of doing that as well, so that we can start moving towards making sure that the process is sporicidal as well as bactericidal. Now I'm going to switch to care homes. You're getting a whistle-top tour of everything that's in my head at the moment. So post-pandemic, we're all aware of the care home situation. The Textile Services Association, which is a trade body for laundries or chemistry companies for the whole industry within the UK, funded a piece of research as a social conscience piece of research to actually find out what was happening in care homes with their laundry and what guidance, help, support they needed to be able to effectively decontaminate the textiles on site. So there was two things here. We first of all wanted to understand what was happening and engage with care home managers, but also the healthcare workers, because what you will see is the opinions of the managers and the workers really varies here. So what people think is going on and what really happening, I think, is varied a little bit. And also then to develop guidance for care homes that could be used. So we actually had about 1,200 respondents because we did another little follow-up questionnaire. So we put a survey out. So we had well over 1,000 people who worked in care homes answering, which is a really good response rate actually. And this was split roughly 50-50, not quite, between managers and healthcare workers within those environments. And we asked them the same questions, slightly differently formatted in the way we asked, but they were the same questions. So where do settings launder their linen? So a vast majority of them, so 84, 82%, were doing it on site in on-premises laundries. Of the remaining 16 to 70% though, we were seeing laundrettes being used for laundry that was coming out of care homes. And then there was a small percentage that was outsourced commercially. So this is what the healthcare workers were saying. And then I've got a big light on there, so I can't quite see that data. But when the managers, there was OPLs, but again, there's still 25% saying they're using laundrettes for the laundry that's coming out of care homes. So this was slightly worrying. We asked them what types of laundry they were processing, because obviously the residents' laundry is really important, and this is their personal laundry, but it's also much more complex, because unlike a bed sheet, a uniform where we know we've got cotton, we've got a polycotton, we could have wools in here, silks in here, and it's managing those as well. So the vast majority, so 40-ish% was residential laundry. Then we had staff uniforms and then bedroom linen. So there was quite an array of different textiles being laundered here. How often is bed linen changed? Now this was an interesting question. Weekly seemed to be coming up as the largest one, but what you can see is the healthcare workers is saying 23%, whereas the managers are saying 60 to 50%. So there's a little bit of variation going on there. 3 times a week, daily, as required, which I thought was slightly worrying. The healthcare workers were saying 26% at the time was just as they thought it was required, whereas the managers were saying, no, that's not really happening. And then other. So even if we look at the weekly rate, that's not great. What is actually happening with this bed linen? And there isn't a policy. There is not a policy to tell care homes how often they should be returning this. So we have done a piece of research where unfortunately my entire team and other microbiology academics have been sleeping in bed sheets that we've been sampling up to a month. I had to buy lots of chocolates. But what we now know is it reaches about 10 to the 4, which we've seen on healthcare curtains and other things. It reaches about 10 to the 4 and then it stays at about that level. So what we're not seeing is a build-up. I think there's a turnover. I think you've got some dying and some surviving. So we've now sent that off for typing because I think over the course of time the bacteria will change, and I think that's what's going to be interesting. So you'll have to wait and see. But I'm hoping what we can get from that is a bit more of an indication of when beds should really be changed. But it's a 3-day mark where it starts to really go up. Now, whether it's viable to change bed sheets every 3 days, I don't know. But that's where we think the mark is. How well do you think your laundry is being processed? And always is what I was hoping for. But here we can see that it's around anywhere between 40 to 50% of the time they actually think the linen is being processed well enough to be decontaminated, which is really worrying. And rarely is in the 20%. So, well, that says it really, all we need to say on that. And do you have separate areas for clean and soiled linen? Because this is so important. And it was quite varied. I mean, we had about 75% overall saying it was, which is great, but we still got 25% of the care homes. This is only 1,000 people, remember, and that's a small drop in the ocean of all the care homes, with 25% saying they didn't have separate clean and soiled areas, which is really worrying. But something that really come out of this, and it's coming back to one of Emma's points, is everyone wanted training. The main thing is they wanted training, they wanted education, and they wanted guidance. And this come through really clearly, particularly from the healthcare workers. The managers were still quite high, which is the pie chart, between 75, 55%, depending who you ask. But the healthcare workers, it was nearly 87% of them that were saying, actually, no, we really need help with this. We don't know what we're doing, and we would like more help. And with my other hat on, and coming back to something Emma said, I've done a lot of work previously on behaviour change, particularly around hand washing. And one of the key things you need to know is someone needs to know why they're doing something. Now, if you've got a personality like me, if someone just comes along and says, do this, I'm highly unlikely to do it just because they've told me to do it. Whereas if someone says, could you do this because this is the reasoning and this is why it's so important, I'd gladly go and do it. And it's the same for everyone, really. So what we have developed, I've skipped a bit there, we'll just come back to this, but this is where should the key focuses be? Collection is around soiled linen. They're not sure. I think they're quite happy with the everyday linen, but it's the soiled linen they're not so sure about. So what we then did was we did some more in-depth focus groups to really get to the bottom of some of these themes we were seeing and what we needed to put into these education or guidance. But it was very clear that the care homes had little knowledge of any of the guidance, and actually it was the infection prevention control nurses coming in and that were really guiding them, which is great. But actually, if all of the healthcare workers had a better understanding of not the policies themselves, but what they're saying you should do, they'd be better able to deal with it. So the main barriers is the built environment, because a lot of them, and it's the same with the hospital, is they're not set up for clean and dirty areas in laundries. Sometimes it's a room off the back of a building, etc. And I've seen some horrific photographs. And the other thing that come through was laundry is the #1 complaint in care homes. So the #1 complaint that they get is around laundry, particularly around personal wear, etc. So we developed a care home working group, because obviously I'm a microbiologist, so I can tell you all the whys you need to do it, but I don't do audits, I don't go into care homes, I'm not an infection prevention nurse. So through the Infection Prevention Society and the Care Home Special Interest Group, we formed a panel, a working group of, you can see here, expert contribution, there's councils, there's a health protection agency, and then there's lots and lots of people that supported this, creating this guidance, which I haven't got the date in yellow there, 30th of August it was finished after a year. So that's now gone off and it's being formatted. So this guidance was written with me as a scientist, with a chemist who's a laundry detergent chemist, and a whole wealth of experts who work in the care homes and do audits and have seen this from across the country. And we developed the training document, but what we've done in every section is put a rationale for why they need to do it. And it's in really simple terms. So this can be used by the managers, it can be used by the healthcare workers. So it's currently being formatted. We will be on the TSA, are obviously going to put it up, but it will also be on the Infection Prevention Society so that people can access it through there. And also Skills for Care have agreed that it can go on their website as well. So this will be accessible. But a lot of what is in here would also apply to the hospital settings as well. Some of just that guidance that goes through there, particularly home laundering. We won't get started on that because I've got 5 minutes left. So I might just tell you a little bit about that home laundering research that we did. So that guidance is now, thankfully, being formatted. But what we have done is put a lot of appendices in there. So how do you write a cost assessment for your laundry? What does the audit document look like? Fire risk from emollients on textiles. So it does actually go beyond just this is how you launder. It is that whole scenario around those textiles and those laundering. So just before I do the acknowledgements, because I know we're wanting to finish on time, we've also done a fair amount of work on domestic laundering, and we have had conversations with the UK HSA on this, because there is hospitals, particularly neonatal wards, that are using domestic machines for laundering. So we did quite a big piece of research on looking at, do domestic machines perform? So do they reach temperature and do they decontaminate using the bioindicator method? Basically no. Depending on the age of machine, it gets worse. So we were getting about 50% of the 8 machines we tested showing that. So they don't hold temperature, they're not decontaminating. We then also did some looking at biofilms within those machines. So we looked in the rubber rim, and if it's anything like mine at home, it's, you know, every now and again you think, oh goodness, that needs a good good scrub. So we looked at those rubber rims, but we also looked, you know, the pipe that goes down the back where the drawer, the detergent drawer is. We looked there to see what was building up within those machines to see if they could harbour bacteria as well, because it's not only about the decontamination of the laundry not being effective, it's about what those machines are harbouring. And we've got so much data, we don't know what to do with it actually, but yes, it's harbouring bacteria. It seems to be Pacific strains, and it can be dependent on the person, which you'd expect, but we are seeing that domestic machines just do not perform. And the other thing that we've seen that's a little bit scary is if you don't dose a domestic detergent exactly as it says on the label, that you can induce not only resistance to the detergent, but cross-resistance to antibiotics. So we have that data, and we're going to publish it, hopefully. Writing's going a little bit slowly towards the end of the year, so it'll be out next year, most probably. But this raises the question about domestic laundering of healthcare uniforms, I would say. So these are all the people I'd like to thank. So we've got the infectious disease research team, we've got the analytical chemists, and obviously all the partners that have been involved, but also all the funders, so the global funders of the research that's going on at the moment.